Right. A very good evening. Welcome to the platform of Arise. So, myself, I'm Dr. Rameshri. I teach Obstetrics and Gynaecology. So, today we'll start with the session where we are doing the clinical based MCQs. So, I'll be continuing with the clinical based MCQ discussion. A very good So, we'll be continuing with the clinical based discussion. So last mid-exam, you have told that there were plenty of questions which were very big. So I have tried to keep one clinical-based question. See how much of a big the question is. They are very simple to solve unless when we understand the question. Okay. So let's start with the first question. A 19-year-old woman presents at 13 weeks of gestation with vaginal bleeding and smelly watery discharge. She feels generally unwell and has had fevers for the last 48 hours. She initially thought she had gastroenteritis as she had reduced appetite, abdominal pain, vomited, and had loose stools. All her booking bloods were normal and the 11-week nuchal scan was reassuring. She had a previous normal vaginal delivery at 38 weeks of gestation. She has no significant gynecological or general medical history. So first and foremost, the things which we have to consider in this question are she's a 19-year-old. She's come to you at 13 weeks and she has bleeding and smelly watery discharge. She also has fever for last 48 hours. So bleeding, foul smelling discharge, fever for 48 hours. Whenever you have a bleeding per vaginum in the first trimester, what are your differential diagnoses when a patient comes to you with bleeding in the first trimester? So I want you to think in terms of that first. She initially thought she had gastroenteritis as she had reduced appetite, abdominal pain, vomited, and had loose stools. All her booking blood were normal and 11-week nuchal scan was also normal. Okay. So apart from these, everything else are normal. On examination, temperature is also 38.1 degrees Celsius. Pulse rate is 96. Blood pressure is 110/68. She looks flushed and her peripheries are warm. Chest and cardiac examination are normal. She is tender over the uterus. So there is a tender uterus, which feels approximately 14 week size. So uterus is corresponding. There is no guarding or rebound. On speculum examination, os is closed, but offensive bloodstain discharge is seen. Bimanual examination reveals a very tender and hot uterus that also feel boggy. No adnexal masses are palpable, but bilateral adnexal tenderness is evident. After reading so much question, I want you to tell what did you, from the entire question, what are the important points which the question is trying to tell? Point number one, she is first trimester, so early pregnancy complication. Next, there is sepsis. There is sepsis. So there were so many points which are telling us that there is a sepsis. That is smelly watery discharge, temperature raised, tender uterus, tender adnexal mass. All these suggest that there is some sepsis, right? On TVS, there is a single intrauterine gestational sac, fetus present with crown rump length of 42.7. Fetal heart rate is absent. What is the diagnosis? Missed abortion, septic abortion, complete abortion, unruptured ectopic pregnancy. Excellent, Gopal Krishna. Correct. So this is a case of septic abortion. So you are absolutely correct by telling this is a septic abortion. So it's actually a missed abortion which has landed up in sepsis. It's actually a missed abortion which has landed up in a sepsis, right? So why are we saying that this is a septic abortion? So any abortion associated with evidence of infection of uterus and its content is called as septic abortion. The most common organism associated with septic abortion is group A streptococcus, that is Streptococcus pyogenes. To call it as a septic abortion, the evidences which are supporting that this is a septic abortion in our question also was there should be a history of pregnancy or abortion. So she has a history of pregnancy or abortion. Fever 38 degrees Celsius or more for at least 24 hours. So she had fever for 48 hours. Offensive or purulent vaginal discharge. There was purulent discharge in her. Lower abdominal pain, tenderness. So there was tenderness also. Tachycardia of more than 100. So it was perfectly fitting into all these. There was history of abortion, there missed abortion. There was fever. There was offensive or purulent vaginal discharge. There is tenderness and there is tachycardia. So all were pointing towards the septic abortion. So what is the management whenever you have a patient with septic abortion? Give her antibiotics. And whatever might be the reason for the septic abortion, you have to remove it. So dilatation and curettage. Posterior colpotomy you will do whenever there is a pus in the pouch of Douglas. Laparotomy and last resort is hysterectomy. So that was about the first question. Let's go to the next question. The serum beta HCG of a symptomless woman with a pregnancy of unknown location has dropped by more than 50% after 48 hours. What is the next step you advise? The serum beta HCG of a symptomless woman with a pregnancy of unknown location has dropped by more than 50% after 48 hours. What is the next step you advise? Okay, so what about this question? What do you mean by pregnancy of unknown location? So I have an answer of repeat beta HCG after 48 hours. Actually, there was a similar question asked in FMG mid-exam. So that's the reason why I kept this question again. So whenever the patient's UPT is positive, UPT is positive, but on TVS, when you don't find the gestational sac anywhere, then gestational sac is not seen either in uterus or in the tubes or nowhere you can find the gestational sac. Then we call it as pregnancy of unknown location. The minimum beta HCG to visualize a gestational sac is on TVS is 1500 international units. Right? So the minimum beta HCG to visualize a gestational sac is 1500 international units. When it is less than that, you will go for serial beta HCG monitoring. Serial beta HCG monitoring every 48 hours. Then we'll go for serial beta HCG monitoring every 48 hours. So if there is rise in beta HCG, by more than 63%, then it is a intrauterine pregnancy. If there is a rise in beta HCG by more than 63%, it's a intrauterine pregnancy. If there is rise in beta HCG by more than 50% but less than 63%, I will suspect that is it tells me that I'm dealing with a ectopic pregnancy. If there is a fall in beta HCG or rise is less than 50%, then I'm dealing with a miscarriage. It's a failed pregnancy or a biochemical pregnancy. So it is not going to develop as a baby at all. So when there is no gestational sac at all and beta HCG is also dropping down, I don't require to do anything here. What will I do? Just repeat UPT after 14 days to see that everything has the entire beta HCG is neutralized or not, has become zero or not, right? Ectopic pregnancy, I have to treat accordingly. I have to wait for the sac to be visualized and then I have to treat accordingly depending on the size of the gestational sac. Intrauterine pregnancy, I have to repeat TVS to see the intrauterine pregnancy. Probably I've done too early scan. Now, if we go back to the question, so this is a very, very important table. They can ask you this table in a different format of MCQs. Okay. So if you understand the right. So if you understand this part, this tabular part, it will help you to answer many MCQs. So whenever you are doing serial beta HCG monitoring, if the rise in beta HCG is by more than 63%, it is an intrauterine pregnancy. If the rise in beta HCG is more than 50%, but less than 63%, it is ectopic pregnancy. If there is a fall in beta HCG, or rise less than 50%, it is a failed pregnancy. So you just repeat UPT after 14 days. Now going back, this patient, you all answered repeat beta HCG after another 48 hours. So it is pregnancy of unknown location. It tells me that on TVS there was no sac, although UPT was positive. They've already done beta HCG every 48 hours. And on beta HCG every 48 hours, there is drop in beta HCG by more than 50%. So what is the diagnosis when you have a drop in beta HCG? Now you tell me what is the diagnosis when there is a drop in beta HCG? As there is a drop in beta HCG, it is a failed pregnancy. It's a failed pregnancy, right? So as it is a failed pregnancy, you can just ask her to submit a urine pregnancy test after 14 days if she stays asymptomatic. Understood? So that is how your tabular form will help you to answer any of the clinical based MCQs pertaining to PUL, pregnancy of unknown location. Let's go to the next question now. Very good. Chakri and Shahid Afridi and Gopal Krishna. Excellent. Patient age 31-year-old, Gravida 3 para 2 living 2, diagnosed by ectopic pregnancy in left tube, and size of the mass is 4 centimeters and positive FHR. Patient has mild over abdominal. What is the management? There's a lot of disturbance outside actually with the crackers. Right, what do you want to answer for this question? Try to choose some option, then I'll speak about it. Okay. So I have answers coming out as D. Right. So I have some of you answering D, some of you answering B. Let's see whether D is correct or B is correct. Let's now go through the management of ectopic pregnancy. So this is management of ectopic pregnancy as per NICE guidelines 2019. So they are a recent set of guidelines. So these are recent set of guidelines. In case if you have written something else in your notes, you can correct it because these are the recent guidelines. Okay. So I tried to incorporate this topic today because all the points which I'm telling are pertaining to the recent advances. Okay. You have three modalities of management: expectant management, medical management, and surgical management. Expectant means you're just waiting for it to undergo tubal abortion, right? Expectant means you're just waiting for it to undergo tubal abortion. What are the conditions where you will go for expectant management? So, when patient is ready to come for follow-up, when patient is stable and pain-free, when gestational sac size is less than 3.5 with no FHR. Okay, so you are going to do expectant management when patient is ready to come for follow-up, when patient is clinically stable, and very, very, very important, gestational sac should be less than 3.5 with no FHR. This should imprint into your brain. This should imprint into your brain. Okay. Fourth point is when serum beta HCG level is less than 1000 international units per liter. When serum beta HCG level is 1000 international units per liter. Now let's see, when do you do medical management? In the medical management, you mainly give methotrexate. Dose is 50 milligram per meter square. 50 milligram per meter square. Okay. Now, what are the conditions where you are going to do the medical management? 3 points are same. Patient should be able to come for follow-up. Patient should be clinically stable and sac size should be less than 3.5 with no FHR. So these 3 points are same for expectant management as well as medical management. The only change is expectant may beta HCG level is less than 1000. Here the beta HCG level is less than 1500 international units per liter. Here the level is less than 1500 international units per liter. Now all this time there was lot of confusion regarding these points, because each book used to give something different. But now NICE guidelines have clearly given, so you can blindly follow the NICE guidelines. Okay. Next, coming to the surgical management, what are the conditions where you'll go for surgical management? When patient has significant pain, when sac size is more than 3.5 centimeters with FHR, when sac size is more than 3.5 centimeters with FHR, and when beta HCG is more than 5000 international units per liter, and when beta HCG is more than 5000 international units per liter. So if beta HCG is less than 1000, you're going to do expectant. If beta HCG is less than 1500, you're doing medical. And if beta HCG is more than 5000, you're doing surgical. So what are you going to do if beta HCG is between 1500 to 5000? If beta HCG is between 1500 to 5000, you can either do medical management or you can either do surgical management. If beta HCG is between 1500 to 1000, you can either do medical management or you can either do surgical management. I don't know if you're able to see this tabla form, but this is a very, very important tabla form which you should be jotting down in your notes. Okay. In surgical management, which is preferable mode of surgical management? Salpingectomy is a preferable mode of surgical management. Can anybody tell me why salpingectomy is the preferable mode of surgical management? Anybody can answer why is salpingectomy a preferable mode of surgical management? Think and answer. You also have salpingotomy and salpingostomy. Gotomy is you put an incision, remove the contents and suture it back. Gostomy is you put an incision, remove and keep it open. You keep it open. Okay. Excellent, Hariharan. You prefer salpingectomy over salpingotomy or gostomy because with salpingectomy you don't have the risk of recurrence. You don't have the risk of recurrence. But with otomy and ostomy, you have recurrence high. So where do we go with otomy or ostomy? When you have like a patient who wants to have pregnancy in future, and she has only one tube left. Such patients may I'll go for gotomy or ostomy. Okay. And when you're giving medical management, that is methotrexate, you will give only you have to check the beta HCG post giving methotrexate on day 2, day 4, and day 7. From day 2 to day 4, there should be a drop in beta HCG by 15%. From day 2 to day 4, there should be a drop in beta HCG by 15% from the previous value. It means she is responding. If the drop is less than 15%, you have to repeat the dose. Maximum you can give like that 3 doses. Okay. Apart from methotrexate, you can also give some other drugs also for the medical management. So the other drugs which you can give for the medical management are, most postgraduate males are very knowledgeable. Most postgraduate males are very knowledgeable. That is methotrexate, PGF2 alpha, mifepristone, actinomycin, vasopressin, and KCL. See, methotrexate is for M, postgraduate PGF2 alpha, males mifepristone, R actinomycin, vasopressin, knowledgeable KCL. Let's go back to the question now. Now you tell me, is B correct or D correct? So as the sac size is 4 centimeters, you can close, it is definite here that there is no point in medical management, right? And positive FHR. So it directly tells me I have to go for surgical management. Now, which surgical management is preferable, ectomy or gotomy? As she's a multi-family, almost living 2, I think the preferable is going for salpingectomy. You don't require to go for otomy. Okay. So that is regarding the management of ectopic pregnancy. That is regarding the management of ectopic pregnancy. A 20 years old woman has been brought to the casualty with blood pressure of 70/40, pulse rate of 120, and a positive urinary pregnancy test. She should be managed by. A 20 years old woman has been brought to the casualty. So, whenever you have a patient with positive urine pregnancy test and shock, most of the time you're dealing with ruptured ectopic. Ruptured ectopic. For ruptured ectopic, you definitely do resuscitation. But post resuscitation in ruptured ectopic, do you do medical management? Do you give methotrexate? No. So this. See, I agree to you. It's a ruptured ectopic where patient is in shock. You have to resuscitate her. But post resuscitation, do you give her methotrexate? No. The actual answer for this should be immediate laparotomy plus simultaneous resuscitation. You don't resuscitate and go for laparotomy. You take the patient to the laparotomy and simultaneously you're going to resuscitate her. One side you can start on fluids, another side you stop the bleeding by removing that fallopian tube. Unless until you remove the fallopian tube, you are not going to sort out her problem. So we are going to go for immediate laparotomy. Immediate laparotomy. Okay. Very good, Alpana. Huh? So the best answer here is immediate laparotomy. Okay. Next, let's go to the next question. All of the following are features of ovarian pregnancy except fetal sac must occupy the position of the ovary. Fallopian tube on the affected side must be intact. Ovary must be connected to the pelvic wall by IP ligament. Ovarian tissue must be in the sac wall. In the near time, we had a question where they've asked what is the criteria name for abdominal pregnancy. This was one mid-exam question. So abdominal pregnancy, it is Studi-Fort's criteria. Abdominal pregnancy, it is Studi-Fort's criteria. So in abdominal pregnancy, how do I remember that the name of the criteria is Studi-Fort's is? How do I remember that the abdominal pregnancy you have Studi-Fort criteria is? Stud are the one who have the abs. Studs are the one who have the abs. So abdominal, remember Studi-Fort's criteria. Okay. Ovarian pregnancy, the criteria name is called as Spiegelberg's criteria. Spiegelberg's criteria. Ovarian pregnancy, it is the Spiegelberg's criteria. So Spiegelberg's criteria may to call that this is really a pregnancy, a primary ovarian pregnancy, what are the features they should have? The fallopian tube on the affected side must be intact. Fetal sac must occupy the position of the ovary. The ovary must be connected to the uterus by ovarian ligament. Ovarian tissue must be located in the sac wall. I think there is a lot of disturbance. Is it like you're also having the disturbance coming in the class? Am I audible to you people, or there is a lot of disturbance for you also? So Spielberg's criteria may fallopian tube on the affected side must be intact. See, fallopian tube on the affected side is intact, then only it means it's a pregnancy developing only in the ovary, directly in the ovary, right? Fetal sac should be in the ovary. Yes, sac should be within the ovary, right? And this ovary should be connected to the uterus by ovarian ligament. Okay, right, then it's fine. So this ovary should be connected to the uterus with the ovarian ligament, right? Not to the, if it is connected to the pelvic wall, it doesn't matter for me. But to consider that this is really ovary, it should be connected to the uterus by the ovarian ligament. And when you're removing the surgical wedge resection or something, you have to able to see the ovarian tissue present in the sac wall. So these are the features of the Spielberg's criteria for the primary ovarian pregnancy. Now, what is the purpose of teaching you Spielberg's criteria is 2017 May, there was a question on Spielberg's criteria. And so I thought better we should know it. So here, if you observe, now can you answer? Fetal sac must occupy the position of the ovary is correct. Fallopian tube on the affected side must be intact is also correct. Ovary must be connected to the pelvic wall by IP ligament is false. So ovary should be connected to the uterus by ovarian ligament, not to the pelvic wall by IP ligament. And ovarian tissue must be in the sac wall is also appropriate. Next question. A couple who had 3 consecutive miscarriages has come to see you for the advice of after having a thrombophilia screen. Consecutive miscarriages. What is the most common cause of recurrent pregnancy loss? The most common cause of recurrent pregnancy loss is ideally idiopathic. And the second most common cause of recurrent pregnancy loss is in the first trimester is mainly APLA, right? Antiphospholipid antibody syndrome. The result showed that she has positive to one of the antiphospholipid antibodies. Which of the following is an antiphospholipid antibody? So APLA may, you should know the criteria to the APLA and you should know the treatment to the APLA. You should know the criteria to the APLA and you should know the treatment to the APLA, right? So here they're asking you, what are the antibodies you have pertaining to the APLA? So there are mainly 3 antibodies which should be present in the APLA. That is, so you actually have for APLA Sapporo's criteria. You might ask me, do I require to know APLA? If you have not read APLA before and you're asking me if I have to know APLA, yes, because it was a question in NEET 2019. And now NEET questions can repeat in FMG. NEET questions can definitely repeat in FMG, right? So in the lab criteria, so in the lab criteria, we mainly have 3 things, that is anti-cardiolipin antibodies, anti-beta-2 glycoprotein antibody, and lupus anticoagulant. So in the lab criteria, we mainly have 3, that is anti-cardiolipin antibody, anti-beta-2 glycoprotein antibody, and lupus anticoagulant. In the clinical criteria, we have vascular thrombosis, which can be arterial or venous. Pregnancy morbidity, we have death of the normal fetus of more than 10 weeks, premature birth at less than 34 weeks due to preeclampsia, more than 3 consecutive abortions of less than 10 weeks, and premature birth of less than 34 weeks due to preeclampsia. Yes, these are the 3 things. So clinical criteria, mein one criteria should be at least positive, and that criteria they should have either 3 abortions of less than 10 weeks, or they should have 1 abortion of more than 10 weeks of a morphologically normal fetus, or they should have a premature birth of less than 34 weeks due to preeclampsia. Okay. And lab criteria mein, they should have anti-cardiolipin antibody, anti-beta-2 glycoprotein 1 antibody, or lupus anticoagulant. The titer should be positive at least 2 times 12 weeks apart. The titer should be positive 2 times at least 2 weeks apart, 12 weeks apart. So here they're trying to ask you which antibody. So they're asking you anti-beta-2 glycoprotein 1 antibody. So the option A is appropriate, right? Anti-beta-2 glycoprotein 1 antibody it is. What is the treatment for APLA? Treatment for APLA is aspirin plus low molecular weight heparin throughout the pregnancy. Aspirin plus low molecular weight heparin throughout the pregnancy. Okay. Next. A woman with 20 weeks of pregnancy. Very good, Gopal Krishna. Correct. Aspirin plus low molecular weight heparin is the treatment for APLA. Coming to the next question. A woman with 20 weeks of pregnancy presents bleeding per vaginum. On speculum examination, os is open, but no products have come out. The diagnosis is missed abortion, incomplete abortion, inevitable abortion, complete abortion. Okay, so I have answers ranging between B and C. Right. So now quickly we'll go through the abortions and come back and see whether the answer B is correct, C is correct, or D is correct. I have some of you answering D also, right? Okay, we'll come back and see whether which answer is correct. So, first and foremost, the clinical picture of abortion mainly follows a triad. What is the triad which the clinical picture of abortion follows is amenorrhea, after amenorrhea, they'll have bleeding, and after bleeding, they'll have pain. Amenorrhea, bleeding, and pain. Okay. First type of abortion, threatened abortion. So threatened abortion is like, it is threatening you that it will get aborted, but it doesn't get aborted. So threatened abortion also same symptoms, amenorrhea, bleeding, and pain. Uterus will be equal to the period of amenorrhea. So if she is 12 weeks, it will be 12 week size. Os, internal os and external os will be closed. Treatment, bed rest, reassurance. You can give progesterones also, but not acceptable as a guideline. Next comes the inevitable abortion. So another way of remembering is the two abortions which start with I, inevitable and incomplete. Only in these two abortions, os is open. So whenever you get a question like just like now I showed whenever you have os open, you have to think in differential diagnosis between inevitable and incomplete. Now what is inevitable? What is incomplete? Inevitable may the process of abortion has just started. In inevitable, the process of abortion has just started. Okay. In incomplete, the process of abortion has started and some products have come out. So again, for inevitable, the symptoms are same, amenorrhea, bleeding, and pain. Incomplete may also it is amenorrhea, bleeding, and pain. Inevitable may uterus is equal to period of amenorrhea. Os is open. See, it is still equal because no products have gone out. Os is open, but no products have yet gone. And here the process of abortion has gone to that extent that I cannot reverse it back. So there is no point in trying to save this. So the treatment is misoprostol. And the dose of misoprostol is 800 micrograms per vaginal or sublingual. Mainly per vaginal is what we give. So 800 micrograms per vaginal. Incomplete abortion may, as some products have gone out, so uterus will be less than period of amenorrhea and os will be open. Treatment here also is misoprostol. Here you can give misoprostol 600 micrograms. Okay. Followed by incomplete, we have complete abortion. Complete abortion may all the products have gone out. And as all the products have gone out, her pain and bleeding is relieved now. So, pain and bleeding subsided. Uterus will be again less than period of amenorrhea. As all products have gone out, uterus will be less than period of amenorrhea. Os will be closed. Treatment, as everything has gone out, I don't require to do anything. I'll just give her antibiotics. Next is missed abortion. Missed abortion is also called as incarcerated abortion. or it's also called as carneous mole. It's also called as carneous mole. So here also again same, she'll have amenorrhea. Instead of direct bleeding, they'll have brownish discharge and mild pain. So again they're following that ABP. Uterus will be less than period of amenorrhea. Because it's a dead fetus, uterus don't grow according to the gestational age we think. So uterus will not grow according to the gestational age we think. Os will be closed. So please see, only inevitable and incomplete may os is open. Here, this is not a clinical diagnosis. Missed abortion is not a clinical diagnosis. You do a scan on TVS. When crown rump length is more than how much? I want you people to answer. When crown rump length is more than 7 mm with no FHR, or when mean sac diameter is more than 25 mm with no fetal pole, we call it as missed abortion. And if you have observed this on the scan, what should be your next step is also asked as an MCQ. Even if you observe this on the scan, the next step is not termination. So what is the next step? Next step is repeat scan after 1 week. Preferably first trimester, you always prefer TVS, transvaginal, because you are seeing something which is in the pelvis, right? So repeat TVS after 1 week. Repeat TVS after 1 week. So after 1 week also, if you see the same, then you go for termination. Then you go for termination. And what is the mode of termination which you're going to follow? The mode of termination it will be always first medical, right? Then later only we go for surgical if medical fails. So you can use here Mifi and misoprostol. Now you can ask me, why didn't I use mifepristone for inevitable and incomplete? Because wahan pe os is already open. So I didn't require to use mifepristone there. But here, as os is not open, I will go with day 1, 200 milligrams of mifepristone. Day 3, 800 micrograms of misoprostol per vaginal. Success rate is 98% with Mifi-Miso regimen. There was one more MCQs in your mid-exam. If you remember, what is the method of choice for termination at 14 weeks? At 14 weeks, the method of termination of choice is misoprostol itself. And what is the dose of misoprostol? Maximum dose of misoprostol. So 14 weeks beyond, you can use 400 micrograms per vaginal every 4 hours, every 3 to 4 hours for maximum 5 doses. So you give maximum 5 doses was also one of the MCQ which they have asked, right? Okay, so I have a query here. No, where will be the blood gets accumulated? In inevitable abortion, you don't have any accumulation of blood. There will be blood coming out, but there won't be any accumulation of the blood. Okay. What are the conditions where uterus can be more than period of amenorrhea is when they have a fibroid, or when they have a macrosomia, or when they have a polyhydramnios, when they have a multiple pregnancy, when they have a complete mole. These are some of the conditions where you can have uterus more than period of amenorrhea. Okay. So now this is about all the types of abortion. Very, very, very important, this tabular form, and you should be in a position to revise and reproduce. I've also taught you in the treatment also. So they can either ask you treatment, they can either ask you as a clinical scenario. You should be in a position to answer. My way of remembering is those abortions which are starting with I will have os open. Now going back to the question, and this missed abortion ka TVS criteria also many times asked as an MCQ, guys. So going to the question now, Os is open, but no products have come out. So both may os is open. Complete, though I'm not thinking, because complete may os will be closed. Missed abortion also os will be closed. So it cannot be these two. Now, how will I understand whether it is inevitable or incomplete? Os is open, but no products have come out. In incomplete abortion, products will come out. In inevitable may, it has just started. So products won't come out. So it is a inevitable abortion. So the answer here is C. The answer here is C. Okay. Right. Okay. So I have queries here. So Gopal, inevitable may there is no accumulation of blood. Accumulation of blood is seen in abruption. That's different again. Concealed abruption also, it can be more than period of amenorrhea. Very good, Shahid. Okay, day 2, can we give folic acid? Matlab, you're asking me day two of her pregnancy. Yes, you can give. Actually, when should you start folic acid? Folic acid should normally be started 3 months prior to conception. Folic acid should be started 3 months prior to conception. If not 3 months, at least 1 month prior. If not 3 months, at least one month prior. Okay, we'll see one last question before we end the today's session. Most common karyotype for partial mole: 69XYY, 69XXY, 69XXX, or 46XX. So partial mole, is it diploid or triploid? So definitely it can't be 46XX because partial mole is triploid. It can neither be 69XYY. Why? Because you never have two Y chromosomes at one place. That's not possible, right? So it should either be 69XXY or 69XXX. Let's see which is more commoner, okay? So why do we have complete mole or partial mole is when you have in complete mole, empty ovum fuses with 2 sperms, or empty ovum fuses with 1 sperm which will duplicate again. In complete mole, empty ovum fuses with 2 sperms, or you have empty ovum fusing with 1 sperm which will duplicate again. Right. So on the whole, it will result in the formation of zygote. And this zygote is completely from father, because it is having all chromosomes from father itself. There is no maternal DNA. So that's why you also call it as androgenetic mole or paternal mole, right? You have combination of 46XX or 46XY. Here, the most common is 46XX. Duplication is most common. Partial mole mein, egg also has chromosomes. Ovum also has chromosomes that fertilizes with 2 sperms, or it fertilizes with single sperm which duplicates again. Single sperm which duplicates again. The most common is 2 sperms fertilizing with it. So it can be either 69XXY or 69XXX. So you commonly see 69XXY combination more. You commonly see 69XXY combination more. Okay. So going back, yes, I see many of you answering B. B is the correct answer. 69XXY is the better combination which you have as a correct answer, right? Okay, so those were some of the MCQs which we discussed today. So basically today we discussed abortions, ectopic pregnancies, and molar pregnancy. More questions on those, right? Now I'll be coming back to you another 3 sessions. So what do you have any particular topic? Images, I'm going to put one session complete images. Don't worry about that. Like, quick roll of all manures and all USG pictures. We'll see all that. Okay. Apart from images, do you have any topic which you felt very difficult and you want me to discuss as a clinical based MCQs? You can put forward so that I can discuss that topic. Right. So you can think of it and you can put a word to me. I'll definitely do that topic for all of you. So again, I'll come back tomorrow with some more MCQs, which can be most likely asked in our exam, and so that we get a very good score in obstetrics and gynecology. Right. Okay. So I'll try to put more questions from multiple pregnancy. Multiple pregnancy is very easy. Don't worry. I'll definitely put questions. GTN, contraception, abortion. Right. So tomorrow I'll try to give more questions on this. Right. We'll try to do more MCQs so that you can get more confidence. Yes, I'll share the PDF with your coordinator. Don't worry. Okay. Amenorrhea. Yes. I have another 3 sessions, so I'll try to concentrate more on these topics so that you become perfect with these topics. Cancers are always like, we try to become perfect, but always little confusing. But I feel cancers are easy. Don't worry, we'll do somewhere in cancers also little bit. Okay. Thank you guys. All the best. Keep studying. And I'll tell you what are the most important topics. Like, must exam may 100% can come. Amenorrhea is one topic. I feel yes, it can come because you had question 2 or 3 questions mid exam may also amenorrhea may. Miscarriages, ectopic, that first trimester ke complications are also some very important, right? Cancers mainly cervical cancer, and last time they asked you vulval cancer also. So vulval cancer also probably I'll put some questions. I think I've discussed. I don't remember, but yes, so that we have an idea of vulval cancer and we answered it correct. So contraception again, yes, you had so many questions asked. So these like some very very important topics, and so that whatever we have read should repeat in your exam. We'll try to target that way only and discuss. Don't worry. Okay. Thank you guys. All the best. Keep studying. See you again tomorrow.